presentation is going to be recorded, but my name is Tracy Summer. I'm going to be helping to facilitate today's webinar hosted by Max, the Maryland Addiction Consultation Service. Max provides support to prescribers and their teams and pharmacists across Maryland in addressing questions and needs of your patients with any substance use disorder or questions about pain management. All services are free. I'm just going to do a brief overview of our program, but all services are free. For phone consultation for clinical questions, we have a consultation warm line available Monday through Friday. We also help with finding resources and that information. We do a lot of education and training, just like today's webinar. And then we have technical assistance to practices who are expanding or starting to implement, let's say, like office-based treatment. And then we have our tele-echo clinics as well. So you'll see on the screen also, Marcielle is on our team. So she'll be helping to put some information into the chat throughout. Before we dive in, I'm going to go over some housekeeping items and the process for earning credit for today's training. Please use the chat throughout today's training if you have questions, and there will be time at the end for questions that we can go over. A copy of today's slides and this recording will be uploaded to our website in 1 week. The process for earning credit for today. In order to get credit, you must be online for the full duration of today's training, and you must complete the eval survey in 7 days from today. Immediately after today's session, we will put the login to your Oasis portal into the chat, and you'll be able to go into your portal to access that eval. And again, you must be online for the full duration. You must complete that eval, and your CE certificates, whether it's CME or CEU, will be accessible immediately after that eval through your portal. I'm now happy to introduce our speaker for today. So today we have with us Dr. Mark Fishman. Dr. Fishman is an addiction psychiatrist and the medical director of Maryland Treatment Centers and a member of the psychiatry faculty of Johns Hopkins University School of Medicine. Dr. Fishman leads the Maryland Treatment Centers, which is a regional healthcare provider, including the Mountain Manor Treatment Centers in Baltimore and in Emmitsburg, as well as several other inpatient and outpatient programs in the state. In this role, he's involved in the development and implementation of innovative programming in addiction and in co-occurring disorder treatment. His specialties include treatment and as well as for dual diagnosis in youth, for opioid addiction in adolescents and adults, and addiction with co-occurring psychiatric disorders. His research work has focused on medication treatment for SUDs, as well as models of care and treatment outcomes in youth, and particularly for opioid use disorder. He has been a past president of the Maryland Society of Addiction Medicine and is currently a member of its board. So Dr. Fishman, thank you so much and welcome. I am now going to turn it over to you.
Great. Well, thank you, Tracy. Thanks everybody for joining us this afternoon. And thanks for your interest in youth, or youths, as they say in Brooklyn, and appreciate your guys doing what you do. And maybe some of you are treating young people. Some of you might be interested in treating young people and coming over to the dark side. No, that's a joke with me, but I'm very enthusiastic about this and hope that you are too. And certainly it's a much needed and underdeveloped, I think, realm of treatment. So we're going to do a whirlwind today. It's obviously a big topic. We can't do it all in an hour, but I'm going to touch on a variety of subjects just to give you a taste. We're going to talk a little bit about developmental vulnerability, what it is about young people that makes them particularly susceptible to these problems. Talk about who's using what, a little glimpse of the trends, focus on two particular substances, cannabis, not because it's necessarily the most dangerous, but because it's certainly one of the most prevalent and lots of discussion about it, and important for people to know about what's going on with cannabis and cannabis use disorders in young people. Some focus on opiates because that is certainly very dangerous, and we're seeing alarming rates of rise in fatal and non-fatal youth opioid overdoses. And then interspersed throughout some talk about treatment, some developmental specificity in that treatment, and in particular, one of my favorite topics, family involvement. So hold on to your hat and let's get going. And here are my disclosures. I think the most important ones are that I've done some consulting for some drug companies that make medicines for the treatment of opioid use disorder. I hope that that doesn't bias me, but you be the judge. Here are our learning objectives, and let's get started talking about developmental vulnerability. The first, I think, tagline is that we want to think about substance use and substance use disorders and addiction as developmental problems of pediatric origin. So there is developmental vulnerability. Things get started in the teen years, typically, and this has been going on a long time, since the beginning of the human experience with intoxicants. And just a word on perspective, we as adults understand and have an intuitive understanding of risk and risk behaviors in young people, not just substances, but other things. And on the other hand, it's easy to let the generation gap widen and to do finger wagging, and rather than help encourage the next generation and have them learn from our mistakes and encourage them to make better choices and reach new promising goals, too easy, to criticize them as being naughty. So just a fun little quote. We live in a decadent age. Young people no longer respect their parents. They are rude and impatient. They frequent taverns and have no self-respect. There's a kernel of truth in that, but we want to be careful to help young people with messages that are digestible rather than stern lectures from a dizzying height. Any guesses when this might be from? Here, check this out. As I say, it's been going on a long time. So it happens in every generation, and we want to learn, that we can narrow this gap and be stewards of improvement in each generation. So here's another perspective on developmental vulnerability. This is substance use. This is past month substance use. So it's not necessarily indicative of problem status or use disorder, but relatively current use for these 5 substances: alcohol, tobacco, binge alcohol, any illicit drug, and cannabis. And we're looking at prevalence in the US population across the lifespan. And you notice on the left, the second decade of life is expanded, and on the right, the rest of the line is condensed. And that's because on the left is where the action is, right? That's the ascending limb of the curve. We see that this behavior of using intoxicants tends to begin in the early to mid part of the second decade of life, the teen years, and has peak prevalence at the end of the second decade of life and the beginning of the third decade of life. It's not that there aren't plenty of people on the right-hand side of the curve that are using substances. Of course there are, and that's where we typically encounter most of them. But when did they get started, right? 95% of adults with a substance use disorder began before the age of 18. So that's why we have to be so concerned. And to the extent that this is a chronic, remitting, relapsing disorder, we have the notion, supported by lots of evidence, that earlier intervention before progression, before the disorder crystallizes in its most advanced malignant forms, that's when we can perhaps intervene with the most success. Here's another view of development. This is looking at the rates of adult substance use problem status, defined in this particular study as having one or more of the symptoms of substance dependence from DSM-4, stratified by age of onset. So we're looking at tobacco, alcohol, or cannabis, those that started before the age of 14, those that started between the ages of 15 and 17, and those that started after the age of 17. Just 3 short years in a narrow developmental span in the life of a teenager, but those 3 years take up a lot of developmental action, as you know. And we see that the difference between below 14 initiation and after 17 initiation confers between a 2-fold increased risk to an 8-fold increased risk in the chances of having problem status in adults. And if you look across the top at initiation before the age of 14 for all 3 of these substances, that's associated with a 25% risk-ish of adult problem status. So we don't need to exaggerate. It's not everybody that initiates that gets into trouble. Lots of teen experimentation stops spontaneously and doesn't progress, but 25% is a pretty big number. Why is that? Well, we could spend a long time talking about what we know from psychology, about mind, brain, spirit, social development. But just a quick glimpse, we know that the earlier, as I say, somebody initiates, the worse they have in terms of prognosis and the higher their risk of progressing to loss of control, to substance use disorder from experimentation and persistence into adulthood. And it has to do with what we commonly know about adolescent maturation or immaturity, as the case may be, during this critical development period. And all of the things we might think about teens, on average, they tend to be more impulsive, more excitement-seeking than mature adults, more difficulty delaying gratification, poorer difficulties with emotion regulation and executive function inhibitory control. This picture here is just one example of the progression of brain development into the 3rd decade of life, where brain constituents called gray matter decrease in their density and white matter increases. And that's only one example of the many ways in which this happens. So a peek inside the black box, but adolescents are more vulnerable and less able to manage the reinforcing properties of intoxicants and less able to stop at just one. And given those vulnerabilities, swim in the water of our culture, in which intoxicants are commonly associated and advertised and glorified as a sign of the good life, a sign of happiness and well-being, a sign of luxury, of commingling with the stars. And here are just some graphics, to remind us of what that's like. That's hard for adolescents to resist and hard for us to message against. We do our best, but we're swimming upstream. All right, that's development. Let's take a look a little bit at who's using what and what the trends are. This is the trend of who's using what kind of turned on its head, the reciprocal of non-use. An interesting way of saying it. It's the same information, but it's displayed in a different way. And the reason that the authors of this study did that is because when you talk to young people, or parents, or policymakers, or teachers about youth and substance use, you tend to hear people say, well, everybody's doing it. So what are you bugging me about, Dr. Fishman? I'm no different than my other peers, or my kid is no different than the other kids. Everybody's doing it. What's the big deal? Well, the data shows us that a lot of people are doing it, but not everybody. So, for example, take a look at the cannabis line. This is, by the way, lifetime use in 12th graders. So this isn't problem use, this isn't current use, this is ever initiated. And the cannabis line, about half of 12th graders have used cannabis. That's a lot, but it also means that half have not ever. Look at the all substances line. This is the one that was most surprising to me when I first saw the data. This tells us that a third of 12th graders have never in their lifetimes used any intoxicant, cannabis, nicotine, alcohol, or anything. Now, that means that 70% have, so a lot have, don't get me wrong, it is a prevalent behavior, but it's not everybody. So one of the things you might say is, well, maybe everybody you know is using. But that's a cohort bias of who your peers are and how people aggregate with like behaviors, but not everybody. The other thing that's very interesting about this data is that look at the trend over time. The trend towards non-use is increasing. The biggest public health story in that domain in the last 100 years, this data doesn't go back that far, but we know is the decrease in the use of tobacco in youth and across the entire lifespan. It's a great public health success. We're having a bit of an uptake now in nicotine use through vaping in the last 5 to 10 years, so stay tuned where that goes. But in general, even with the all substances line, initiation is declining, so that's good news. On the other hand, there is a bimodal distribution probably in which, although fewer are initiating, there is higher rate of progression to significant use, development of disorder, and a deepening of the deep end of the high severity pool. And I'll show you some data later for daily use, for example, of cannabis to make that point. Here is another important trend and category of teen substance use. This is binge drinking. The other is any initiation, but that's a particularly typical pattern of youth use, which is not daily use of half a handle of vodka every day in the morning with withdrawal. You know, that's the picture of a very high severity adult with alcohol use disorder, but it takes decades to get to that level of severity. The typical adolescent or young adult pattern is beginning on the weekends, not every day, but bursts or binges of 5 or more drinks in a setting. And one of the things that's important to know is that adolescence and young adulthood is the time in the lifespan where the rates of binge drinking is the highest. And so here is, this little data is a little older, but it's the current version is similar, that the rates of 12th, 10th, and 8th grade binge drinking are alarmingly high. Now, I don't want to exaggerate. It's certainly not every teenager, but the numbers are high. Again, the trend decreasing. Good news. An important thing to know is that there is a reciprocal relationship between perceptions of harm, that is, what is your attitude towards whether a substance is problematic. And this is, you ask young people, is cannabis a problem? Is it harmful? And over time, historically, in eras where people are having less perception of harm, there's higher use, or less use, higher perception of harm. I don't know which comes first, chicken or egg. This data can't tell us that, but they do reciprocate. And that gives us a hint that there may be preventability if we can reach people with digestible messaging about harms and about risk. What are young people using? Alcohol is the most prevalent. Cannabis, as you saw, also very prevalent. The typical kinds of alcohol that is marketed and has most uptake for young people are beer, but also sweet drinks. So hard seltzers are very popular, and pre-mixed cocktail cans are the most exploding segment of the alcohol market generally, but particularly in young people. Cannabis, you know, often the word is weed, but there's a million nicknames for it. The thing, and I'll show you some data about this, about cannabis, right, is that it's available in ways that THC potency is much higher than it used to be, including, as pictured here, wax extracts, sometimes called dabs, with enormously high potency. Nicotine, thank goodness, cigarettes are less cool than they used to be, but vapes are very prevalent, and they're marketed with flavorings, cotton candy, whatever, to young people in particular. And it's not only nicotine available in the solutions, but also THC and who knows what. Opioids, although nowhere near as prevalent, are certainly very dangerous. You all know about fentanyl. Pictured here are counterfeit pressed pills made to look like prescription analgesic opioid called Percocet. These on the street are sometimes called Percs, or in Spanish Perco, or M30. It's all fentanyl all the time. Don't let anybody tell you different. Some kids know that. Some kids don't know that. Some kids know it but don't want to know it. But currently, unlike a decade ago at the peak of the prescription opioid phase of the opioid epidemic, when kids were shopping in their grandmother's medicine chest for leftover medicines, now what you have are these counterfeit pills, counterfeit Perks here, counterfeit Adderall, counterfeit Xanax, and the drug supply broadly, including a little bit of cannabis, may be contaminated with fentanyl in a way that people who are seeking opioids may be getting fentanyl, but even people who are not seeking opioids, rather seeking other substances, may be dangerously getting fentanyl. It's not very common, but you should also know about the cough suppressant dextromethorphan, found in the brand name cold medicine Coricidin, sometimes called Skittles, found in the cough syrup, sometimes in the brand Robitussin, and that's sometimes referred as Robotripping. You won't see a lot of it, but you do sometimes see it, and it's an aspect of adolescent-specific use and not very prevalent in the adult population. All right, let's focus on cannabis for a few minutes. Here are just some images to remind us of what's happening in cannabis land. On the bottom left is a nice depiction of increases in THC concentration in plant cannabis. THC, as you know, tetrahydrocannabinol, is the active intoxicant ingredient that people who use cannabis seek out for its eugenic effects. And the same guys and gals that do breeding of plants to get increased protein content in cereals like wheat or rice can do the same thing for THC content in cannabis. And we have 10+ fold increases in its THC content. It's a different drug than it was 80 years ago. This is not your grandfather's reefer. This is a much more potent, more toxic substance, and used in doses by many high severity young people, as in the upper left-hand corner in blunts and other things rolled up in cigars and the like. On the upper right-hand side is a depiction of industrial production to remind us that this is no longer your stoner neighbor growing 3 skinny plants in his backyard. This is very high-tech, scaled, modern agricultural production, and wait until the big boys and girls on Wall Street get a hold of it. There are still federal restrictions on the commerce laws and the banking laws because it's still illegal at the federal level, even though legalized in half of the states. So Wall Street's got hands off, but they're drooling and waiting, and I don't think it'll be long. So I think that spells trouble. And then in the bottom right is the great icon of cannabis intoxication, Snoop, but there are plenty of others of these cultural icons, and that's part of what the cultural advertising, if you will, is that makes it difficult for young people to resist. Why do we care about cannabis? What's the big deal? What's all the fuss? It's not because it's a moral scourge or the devil's weed or it needs to be removed from the face of the earth by any means. I think the best analogy is alcohol, which also is prevalent and pervades the US and other cultures. The question is, who are the people who are vulnerable versus mature adults who might use recreationally, and it's none of my business, none of our business, like alcohol. And youth are particularly vulnerable, as we've been discussing. Those other vulnerable populations include those with psychiatric illness or other substance use disorder, but we're talking about young today. And what are some of the harms? Well, acute intoxication like motor vehicle crashes, so maybe not as severe a risk of motor vehicle intoxication as driving drunk. So the patients say, well, it's not as bad as alcohol. Well, okay, if there's only 2 doors, driving drunk or driving buzzed on cannabis, I guess, but what about the 3rd door, driving sober? So there's maybe half or a third of the increased rate of motor vehicle crashes compared to alcohol, but I still don't want to be driving next to that person. There's a series of psychiatric toxicities or consequences of use. I'll just mention them. We don't have time today to look at the data, but there's emerging evidence that cannabis increases depression and anxiety over time, despite the patient's report that it's the only thing that works. And why can those things be compatible? Well, because it's true that intoxication temporarily relieves distress. And so the nostalgic recall for peak intoxication or peak blood levels is true. I feel less bad when I use, you fill in the blank, alcohol, cannabis, whatever. But over time, the new normal becomes worse and worser. And that's what the data shows us. And the trials that have been done of THC or plant cannabis for depression and anxiety are all negative. That work is emerging. What is settled science, though, is the body of work that shows us the link between psychosis and cannabis. And although most people who use cannabis do not get psychosis, the increased rates, although a minority of people, are quite clear. And when you look at studies that take into account dose and frequency, the rates of the development of psychosis in cannabis users are probably up to 6 times, somewhere between 2 and 6 times the background population. Again, not to exaggerate, most people do not develop that. That is an infrequent occurrence. I don't think that these kinds of warnings are the things that are going to change the behavior of a 13-year-old, but it's important for all of us to know. And then there is some beginning evidence of longitudinal cognitive impairment. This has not yet been replicated, so we don't know if it's going to turn out to be true, but there's at least one well-done study from a large cohort of young people over 10 years looking at cognitive impairment that's CERN. But the most important reason that we are concerned about cannabis is the subpopulation of young people who go further than normative teen experimentation to more frequent use, impairment, loss of control, progression to a use disorder, perhaps progression to use disorders with other substances, and persistence of use disorders into adulthood. Not the majority, but a substantial minority who come to harm. And the question is how to parse out who is at risk, to think about delaying or advocating for delaying of initiation to reduce risk, and intervene in those that are having trouble. Some data that looks at the rates of progression to use disorder based on time from initiation. So this is large population data looking at young adults and adolescents, development of cannabis and alcohol use disorders with time since first initiation. And the take-home message here is large numbers of adolescents and young adults develop use disorders relatively soon after initiation. Again, not to exaggerate, it is not most young people. But within a year, 10% of adolescents, within 3 years, 20% of adolescents. And if you kept going to the right, some estimates are eventually that number might go up to 40%. That's controversial. It depends on which expert you believe, but it's higher than in adults. And it's concerning because of that substantial minority. And what can we do about it? Surely, even if you're an so-called apologist for normative adolescent experimentation, teens will be teens, they get into hijinks, they experiment with risk behaviors in substances, in not wearing a seatbelt, in not wearing a helmet when they ride a bicycle, in terms of sexual interactions, all of those things. We know that about this formative period of life, but I hope most people wouldn't dismiss daily cannabis use as no big deal, just adolescent hijinks. And here's that data. 6% of 12th graders using cannabis daily. The good news, it's only 1% of 8th graders. The bad news is it's as much as 1% of 8th graders. I guess the other good news is we've not reached, again, the higher rates that we had in the late 70s. And the numbers are up and down, but at least recently, it's a relative flat line after increasing, in the 90s. But we'll see what decreases in access, legalization, so-called medicalization. We'll see what that brings. But I think people should be concerned about this. This is Australian data looking at just some of the correlates of what does it mean in terms of impairment to be a daily adolescent user of cannabis. This is just a smattering of some of what these authors found. Rates of persistence of cannabis dependence into adulthood with an 18-fold odds ratio. That's not so surprising. Past behavior predicts future behavior. 3-fold increase in rates of high school dropout, 8-fold increase in rates of using other drugs, 7-fold increase in rates of non-fatal suicide attempts, and the other kinds of typical impairments that you might expect from the progression from experimental use to development of a use disorder, et cetera, et cetera. So what do we do about it? Let's shift to talking a little bit about treatment. Most of you probably know about the SBIRT paradigm. SBIRT stands for screening, brief intervention, and referral to treatment. This is a construct for generalizing a systematic approach to looking for use and use disorder patterns and going upstream from high severity specialty treatment into earlier touch points where you might encounter adolescents earlier in their use careers and be able to intervene earlier. One of the target contexts for that is in pediatric or family medicine practices, thinking of primary care, thinking about other places where you are youth welcoming and serving youth. Well, what about screening for substance use? And for very low risk, that is those not using, encouraging good decision-making, cheerleading for that, talking about continuing delay of initiation, not making moral judgment about nobody should ever get intoxicated, but maybe that's something you might postpone till 18 or 21 or whatever's the right number. For those that have just had some initial experimental use but have not developed impairment, give them brief advice about what are their goals and how furtherance of those goals might be promoted by altering that course of not progressing with experimentation. For those that have early, mild, or maybe moderate SUD, can you develop brief, and we have developed brief motivational interventions that can be done in short amounts of time with general counseling and pediatric caregivers. And then for those that are moderate or severe, thinking about a referral system where they can get to specialty care. But you can see that this cascade, if implemented in a successful way, could start with universal screening and stratify risk profiles to give appropriate kinds of treatment. So what does motivational treatment look like? Let's start with a case, just very briefly. Let's say somebody in a pediatric office or in a mental health setting or wherever, you see a 14-year-old boy, and as you're screening about what substances have you used and how often, he says, I've done some drinking at parties. I've used some cannabis. Maybe it's a couple times this past year. Maybe it's a couple times per month. But either way, I think it's no big deal. But I have no reason to hide it from you. Overall, this is a high-functioning young man doing well at school. Parents are unaware of the substance use. He says, when you ask him, so what do you like about it? What's the pros and cons? Excuse me. He says, well, I like it. It's fun. It's nice to do with the friends. I do notice that I got a little loud and embarrassed last weekend at a party. Maybe I regret that. And I have had the experience sometimes that weed makes me a little weird or makes me isolated or makes me a little paranoid. Maybe he's had those side effects, but overall, no big deal. I can take it or leave it, etc. What are you bugging? And overall, not seeing that it's a problem. So here's an opportunity of somebody with somewhere between experimentation, not progressing to disorder, or maybe we haven't asked that. It's not shown in this case presentation. Maybe he's got some early signs of impairment. Maybe you want to say he's got a mild disorder. I don't know, but this is an opportunity to talk to him about the pros and cons, to talk to him about his goals, to try to clarify with him. We've talked a little bit about some pros. We've talked a little bit about some cons. How is it that you might plan about your future decisions and behaviors? And we're thinking about limit use, trying to give him digestible messaging that it's generally not good for the things he wants to accomplish. And his prognosis at this early stage is probably better than somebody whose use is more advanced to the point of a moderate to severe disorder. But it's an opportunity to be able to have an open conversation and be able to talk about it where the discourse is meaningful on his terms, thinking about his particular goals and trying to win therapeutic alliance, again, on his terms. You guys know about Prochaska and DiClementi's stages of change, the idea that most people don't walk in the door, and certainly most young people don't walk in the door with acknowledgement that they have impairment and they're looking for treatment. They are pre-contemplative at best, more often pre-contemplative, as this other young person and most young people. What's the big deal? I don't see that there's anything wrong with it. And so where we think most of the action is going to be is in motivational approaches, trying to work with them longitudinally to see if we can persuade them about connecting the dots between their use patterns at various different levels and what the rich or impairing components of their lives are like, so we can intervene. But early on, we shouldn't expect that they're going to want treatment, that they're going to suddenly have some epiphany with scales falling from their eyes and say, yeah, you're right, I quit. Rather, it's going to be being able to persuade them that there is, in fact, something that needs to be addressed. Excuse me, I'm getting over a cold. These are not effective treatments. Scare stories, it's the devil's weed. One puff and you'll jump out a window. One puff and you'll kill your grandmother. I don't know if anybody's seen that marvelous old 30s black and white movie, Reefer Madness. You can look it up on YouTube. It's both ridiculous and silly, but kind of funny in an old-fashioned kind of way. It doesn't help. There's no, we can be credible about what's real rather than having to make stuff up. Go look it up on YouTube. It's kind of fun. So what do you do? Excuse me. Just to give you some language about some motivational approaches, and everybody uses their own voice, their own language. You base it on who's in front of you, et cetera. But just to give you some ideas, you talk to a kid who you think has got a problem with cannabis use. They say, yeah, what are you talking about? Everybody does it. I'm no different than the others. I'm doing fine. It's not a problem. Stop bothering me. Rather than doing this, I know better. I'm the doctor. Yes, you have a problem. That's not going to reach anybody. So rather than going up the middle, you kind of do an end around, if you'll pardon the weak sports metaphor. And the idea is start a conversation about, well, maybe you don't have a problem, or maybe you don't think you have a problem, and we can agree to disagree on that. I use that language a lot. That's okay. And I appreciate your telling me about it, but let's talk about somebody else maybe that you do think has a problem. Surely you know somebody, your cousin, your cousin's older brother, your uncle, I don't know, somebody you met at school who smokes too much and is in trouble. Let's talk about why they're in trouble, why it's too much. What are the pros and cons for that person, and what you've seen as evidence of the harms for that person? And what that does is get some of the defensiveness out of it. I'm not necessarily criticizing you. I'm talking about some other abstraction. And even though we may not be on the same page, maybe we're at least in the same book. Establishing a discourse that there is such a thing as too much, that there is such a thing as problems from cannabis. And by the way, why would I, as the doctor or counselor or your teacher or your parents or your boyfriend or your girlfriend or your coach, why would us or multiples of us say to you that you have a problem? I know you think we're full of baloney, which is fine, but can you try to explain what we're thinking? And that's helpful. It's an important developmental exercise to try to get an adolescent to walk in somebody else's shoes, adopt a third-party perspective? Can you at least articulate it even if you don't buy it? Let's talk about the pros and cons. Why start with the pros? Because people wouldn't use if it wasn't good in some way, or fun, or relieving of distress or something. So let's talk about what's good about it. That establishes some credibility. And are there any cons? No, there's no cons. All right, well, no cons now, but, and you say it's no problem, but let's say that things change, and in some alternate strand of the multiverse in the future, something changes. What would be the evidence that you've moved from what you think is not too much to too much? What would be too much? What would be the trouble? What's the line that you would think you shouldn't cross? Like, I only smoke on weekends, I shouldn't smoke on the weekdays. I only smoke with friends, I shouldn't smoke alone. I only smoke after school and after my homework is done, et cetera, et cetera. Okay, right. So what would be those points that those would be red lines? Why would those be problems? And you can see what that does on the same page, but maybe now we're in the same chapter, not just that there is such a thing in other people as too much, but that there could possibly be, if a slippery slope were to occur, something in your personal life that might interfere with your personal goals to be prevented, right? And what that does in some way is set you up for longitudinal monitoring, because when the person comes back and you continue the conversation, you look at your notes and it says, well, you told me you didn't think you should be smoking during the weekdays, but you told me about that party you went to Wednesday and you got blasted. Well, what do you think about that? I've changed my mind, Dr. Fishman. Occasional Wednesdays are okay. But what then you might have over time is a series of lines that are crossed and that you can look at in the rearview mirror to establish that, maybe there's a progression here that you don't notice, but up to your own life, that you can see as the enactment of that slippery slope and the movement towards progression and problem. Well, you say you could stop any time, but you don't want to. Okay, but would you be willing to give it a try? Weed's not going anywhere. So what about cutting down for a couple weeks a month? What about quitting for a little bit? Come back and talk to me about it. And then when they come back and you say, so how'd the cutting down and quitting go? What? Oh yeah, I decided you were even
What?
more full of it than I thought. Of course I'm not.
Okay, well, you can answer it if you need to. We can go to the.
So one of the things is, I wonder if it's harder than you thought. Hey, did you know about cannabis withdrawal? What's that? Well, no, it never killed anybody. You don't need to be in the hospital, but turns out that there's a characteristic cannabis withdrawal syndrome where you get insomnia, where you get irritable, where you get temperature instability. Anyway, some people buy it, some people don't, but it's an opportunity to say, well, why wouldn't you give it a try, sampling abstinence or sampling reduction? But the most important thing in any of these conversations, and you find your own voice, is the longitudinal quality of the conversation. That I'm very pleased that you were able to talk about these things openly and honestly. I don't want you just to parrot, okay, cannabis is bad, I'll never do it. That's not true and it's not helpful. I want your honest reflection. I want to hear what you really think. I want to develop a longitudinal therapeutic alliance with you. And would you come back and be willing to talk about these things with me? Here's another case. 15-year-old girl whose parents bring her to a pediatrician, to a mental health professional, to a counselor, to me, whatever, with some depressive symptoms, some social withdrawal, some irritability, problem in groups. Some adults don't know about any substance use. She also says in front of her parents, yeah, I'm not myself, I'm worried, I'm cranky, I can't concentrate, I'm not sleeping well. They're wondering about a conversation. Could this be depression or anxiety or both? And then she later tells you that, yes, she's experimented a little bit with marijuana and beer, but not recently. It's no big deal. And then over time, it comes out that she's actually using more cannabis than she said at first, and she's using it pretty regularly on the weekends. She thinks that it might be reasonable to get treatment for depression, psychotherapy, medicines, both, whatever, but again, thinks the substances are no big deal. This is an opportunity to use treatment motivation and presentation for problem A, which is important to her and in which she's engaging over, even though she's not motivated to think about substances as problematic. Over time, as you develop therapeutic engagement, hopefully you help her with the depression over time. Maybe you can connect the dots that things will go better in the depression, the thing you care about, and motivate her towards improving that outcome by addressing the substance use. So that's one approach to piggybacking a motivational approach to the presenting motivational treatment problem. One of many tools that you might read about in adolescent substance manuals, the readiness ruler, asking people to rate how important is it for you to change such and such, how confident are that you can change, and if you say you're halfway confident, what would it take to improve it from a 4 to a 7, and that kind of thing, and that's a way of having the conversation. There's plenty of these manuals. Here are just some of the chapter headings or session headings that you might see. I'll skip ahead to show you some of these manuals. Some of them are available for free. We don't have time to talk about the details, but there's lots that's been particularly developmentally specific ways of messaging. But again, you can't do CBT, that is address skills, in somebody who's not interested in getting those skills. So that's why I say the preponderance of our efforts early on are the motivational approaches, connecting the dots to get to active treatment, and are people willing to work on skills acquisition. All right, and in our last few minutes, I want to spend a little bit of time on opioids, not because opioid use disorder is super common in adolescents, although it's very common in young adults, that is, 18 to 26. But in adolescents, it's not as common as other times in the lifespan, but rates are increasing and rates of fatal and non-fatal overdoses are increasing. And here's just a picture of the similar curve that you know from adults in overdose deaths attributable to fentanyl. The absolute numbers in young adults are relatively small, but the rates of increase are high, and perhaps the highest in the lifespan in recent years. We don't really know why that is. I do want to say that there is a prevention message in that, though. Remember, most people with adolescent substance use and use disorder do not progress to OUD. It's a small minority, but some do. And as we think, as I said before, about addiction as a developmental problem of pediatric onset, we know that most young people who initiate opioids didn't start with opioids. It is part of a continuous disorder in which opioid use disorder is a particularly advanced malignant subtype, but we want to think about the broad arc of SUD generally, and those that come to opioids have almost always lost control of other pre-opioid substances, alcohol, nicotine, cannabis. And so thinking about early intervention in teen substance use is in itself an opioid overdose intervention strategy. And that might have implications for garnering more attention and resources to that kind of intervention, which I don't think we do enough of. Important to know that the typical treatments across the lifespan for opioid use disorder, including the FDA-approved medications, are also, or should also, be the standard of care in adolescents and young adults. We've got good research on buprenorphine. We've got emerging research on extended-release naltrexone. We have nowhere near the amount of research that we do 70 years in adults, but an established body that tells us we have safety and efficacy. For sure, these medicines can have side effects. Any medicine, including Tylenol, can have side effects. But the good news is there's been no signal of particular side effects conferred by chronological age. There's no reason to think of these as second line or fail first strategies. That is, let's offer young people non-medication treatment first, and then if they fail that, let's go to medication treatment. No, the medications are the treatment elements that have the evidence. And what does failing first look like in opioid use disorder anyway? We don't want to risk a fatal opioid overdose before we make the decision to choose evidence-informed life-saving treatment. Not everybody's gotten the memo, and there are barriers to uptake. One barrier is that the labeling from the FDA from these medicines does not include younger adolescents. Most of what we do in medical practice is off-label anyway, but that's still an impediment and a barrier for many practitioners and many payers and many policymakers, and that's a problem. I'm going to conclude with just a few words about one of my favorite topics. We don't have a lot of time, but just to mention the importance of family involvement. That's especially true in adolescents and young adults. I happen to think it's important across the lifespan. It's an intuitive, natural thing we do, right? For most medical problems. If your loved one has trouble with a medical issue and has trouble navigating the healthcare system and doesn't understand what the doctor is saying or doesn't agree with the doctor or has trouble sticking with the medicines, you know, we try to help. Granny won't take her pills, you try to help. Not the case so much in substance use disorder, which is secretive and shameful and in the shadows, and that's a big problem. So I am an advocate for including families, for doing so with respect and with consent, but it means getting to yes and thinking about communication that can give a role to family members, not the nagging, not I'm going to cut your head off, not the I'm going to throw you out of the house, but the I can help you with utilizing the healthcare system in a more effective way. And some of the work that my research group has done has focused that on adherence to the medications for opioid use disorder in terms of coaching families about how to help with that. Confidentiality is a sticky wicket, and so we need to be mindful and planful about that. So how should we do that? By following rigid limitations on disclosure. I can't talk to your family, that's against the rules, or by making unilateral and surreptitious disclosures behind your back. I think both of those polar opposites are wrong. The approach is getting to yes, negotiating, winning confidence, trying to build a team that includes a designated treatment significant other, parent or otherwise, that can be part of the team. Patient says to me, you can't talk to my family. Should I say, okay, I won't? Should I say, oh yeah, watch me? Or should I negotiate and say, well, they're going to call, what do you want me to say? And let's talk about planning for that. And what about if we talk to them together? And what if we can find a way that you can make things go better and win points and get what you want and get their support, reduce their punitive approach from the past, and see if they can help you. Now, I'm not always successful with this. I don't want to be Pollyannish. But anyway, that's the goal. All right, so we invite them in. We ask, do you want their help? What if I can run interference and help get them off your back? And I can win points that way by saying, ma'am, I'm talking to the mom now, maybe you shouldn't talk that way to this youngster. Let me see if I can give you a more helpful approach. The kid says, whoa, you said that to my mom? Huh. And maybe that helps the alliance. And then there's coaching the families on how to pick your battles and to know your leverage, and you win more flies with honey than you do with vinegar, and thinking about reward-based approaches and encouragement, etc. Anyway, we're out of time. I want to make a plug for the general principle of therapeutic optimism. We can't always help everybody, but we ought to try. We don't have cures for addiction. There's no surgery. But if we tell people that there is hope and that we can mostly move things forward in an optimistic way, that helps build alliance. And that's especially true for young people and their families. So we got a little bit of time left for questions and discussion.
Thank you so much, Dr. Fishman. This was a wonderful presentation, as always. We are starting to see some questions come into the chat. So I'm going to start to read them off. The first question is, if there is time for questions, yes, absolutely. Can you comment on the role of childhood trauma adversity on the development of SUDs?
Yeah, it's a very interesting question, and we could spend all day talking about it. The first thing that's important is that maltreatment of children and of people across the lifespan is horribly common in our world, and it's a tragedy. So, and it ain't good for people. We know that rates of problems, including substance use, are enriched in populations that have had bad experiences, maltreatment, abuse, other things. We don't know enough about the causal link. So withhold judgment for a second on whether there's something causative there. Certainly it's not good for you to be mistreated, but they do go together in many ways. People who are vulnerable to being misused are vulnerable to lots of things. People who are intoxicated are vulnerable to being misused because of lapses in judgment, because of being in the wrong place at the wrong time with the wrong people. So to the extent, for example, that people have diagnosed PTSD or other co-occurring psychiatric problems, depression, bipolar disorder, schizophrenia, whatever, we got pretty good evidence that addressing those problems concurrently with the substance use is helpful. Obviously, we can't go back in time and undo people's prior history, but we ought to be thinking paramountly about safety for people who are at risk. That's not everybody, but it's a lot of people. So the first thing is, are you at continued risk for being mistreated, being victimized, and what can we do to A, assure your safety, B, get you out of, oops, Zoom does this thing, I don't know why, get you out of the victim role, and C, alleviate your symptoms with the hope that it will also improve your SUD outcomes. But there's lots of more work needed to be done on that. In fact, in figuring out what are the special techniques for treating those co-occurring psychiatric disorders in the context of SUD, because some things are the same and some things are not the same in how we do combined integrated treatment.
Thank you, Dr. Fishman. I know there's some other things that are coming in comments, but another question that came in is, how does the engineering of cannabis and other drugs in combination with the hard driving capitalist culture with no set structural safety net for treatment influence perception of use over time? Baby boomers versus Gen Z.
Wow. Well, I think I've addressed that a little bit, but I'll address it a little bit more. I do think that there's a lot of cultural influences on who uses what. Access is really important. Promotion and advertising is really important. And in a culture in which big tobacco and big alcohol have driven, and big opioid in terms of thinking about the prescription opioid epidemic of a decade ago, not even a decade anymore, but we see examples of how financial incentives to move product mean that people get in trouble. Now, that doesn't mean that that's the only cause. And even in cultures in which alcohol is prohibited religiously or culturally or legally or all three, you still have alcohol use disorder, but you do have it at lower rates. So there's no doubt that access, promotion, the comments I made before about the big boys and girls of Wall Street getting a hold, of cannabis. We'll have big tobacco and big alcohol be first in line in adding it to their products. I believe. I know that's cynical, but I do think there's something there, and that's a problem. Of course, in our culture, this is now political opinion, not medical knowledge, so take it with a grain of salt. We balance freedoms and libertarian access to buyer beware, pick your poison. Think about alcohol, right? We say that people have a right as mature adults to have access to alcohol because most people use it non-problematically. Most people can have a glass of wine with dinner or a beer at the football game, take it or leave it, stop and start, and don't get into trouble. But a significant subgroup do. What's the trade-off in terms of access for the many versus access to those that are vulnerable? Tough questions. I do think, though, that it is reasonable for us to be parentalistic about access for young people. And that's what I'm advocating today, which is to say that young people have no business fooling around with intoxicants. And I say that even knowing that saying that doesn't change it and that it will happen and that many will. But if we can change our view in terms of not being apologists for it, but recognizing it as a significant risk that ought to be addressed, whether it's on a population public health level, whether it's on an individual treatment intervention clinical level, whether it's on a parenting level, which is very important, that is coaching parents on not making excuses. Oh, we did it when we were young. It was no big deal. Wait a minute. This isn't about you. This is about your vulnerable kid and thinking about how you can manage this time in life that is fraught with risk, not just with substances, but with all the other risk behaviors that we know about, and try to keep them safe and try to get them to live through their teens beyond the period of greatest vulnerability. And learning to drink responsibly in my basement or at my dinner table is not an evidence-based intervention. It is a way of encouraging exposure and is bad parenting. Just saying.
Thanks, Dr. Fishman. Someone also asked if the link to today's session and the recording, if it's going to be available. Yes, as Marcial said, that's going to be on our website within 1 week. And then I know we're out of time, but if you have time for just one more question, another question came in, and apologies if I mispronounced some of this incorrectly, but it's, what approach do you use to work with clients that are experiencing cannabinoid hyperemesis syndrome?
Sure. Cannabis-induced hyperemesis syndrome, say that 5 times fast.
Right. Thank you.
Is a toxic effect of high severity or frequent use of cannabis. And most people don't get it, but a substantial minority get it. It's not rare. It's not common, but it's not rare. And it manifests itself as uncontrolled vomiting and nausea. And people frequently present to the ED, to the doctor, to the hospital. It can be very severe. You can get dehydrated. You can get tears in your esophagus. Most people don't get it that seriously, but and people can't figure out, why can't I stop vomiting? The people who have it tend to use cannabis as a way of relaxing, hoping that it will help it, and it may help relieve it in the moment temporarily, but over time, it makes it worse. For a long time, nobody recognized connecting the dots. Now, most emergency medicine professionals and general practitioners know that there is such a thing, and will try to point out to people, the thing you can do here is to cut down or stop your cannabis use. Most people don't do that at first. They don't buy it. The problem is that it doesn't respond to the typical anti-nausea interventions. So you might know about medicines like ondansetron, Zofran, or other anti-nausea medicines. This syndrome doesn't seem to respond very well to that. One of the clues that doctors use in diagnosing it is a large number of people who have it report anecdotally that hot showers seem to give them relief. That turns out not to be true of other sources of chronic vomiting like gastritis or viral gastroenteritis or, those kinds of things, or ulcers. So if somebody is smoking and taking hot showers to relieve nausea, you want to think about cannabis hyperemesis syndrome. There really aren't many medicines that can treat it. The answer is to cut down or to stop cannabis use, but that has the same motivational problems that we've been discussing, because usually substance use disorders or people with substance use disorders are not consequence avoiding, right? They're not thinking about all the medical harms or other impairment that they've had. They're thinking about the immediate rewards. And so that's part of the motivational puzzle that we've been discussing. How do you give them digestible messaging that helps them make their lives better? Not because we think it's a moral problem, but because puking is no fun.
Well, thank you again so much, Dr. Fishman. This wraps up our presentation for today. So again, you can log into your portal in OASIS in order to access your eval. If you're interested in getting CME or CEU credit, you need to do that survey within 7 days from today. And another plug for Max, if you have any questions or things that we did not get to today, please feel free to reach out to us, and our team is happy to help. Dr. Fishman is one of our consultants and would be happy to answer any clinical questions that you might have. So if there are no other questions, then we will end. And again, thank you so much, Dr. Fishman, for a wonderful presentation for today. So have
You're
a
very
great
welcome.
afternoon, everyone.
Thanks. Yeah, thanks everybody for your attention. I hope that's been somewhat helpful. If you've got cases or additional questions, as Tracy said, you can reach me through Max. Happy to talk about stuff. And thanks for caring about young people. See ya.
Thank you. Bye, everyone.